All right, everybody, we're going to go ahead and kick off our session here. And thank you for the enthusiasm and the line, I think, from a food perspective. Hopefully we'll have enough for everybody. But we're really excited to have everybody here today. And I think, fortunately I'm amongst friends here on this panel in this conversation. But what we really want to talk about today is, I think, is really a different technology than what we've talked about a lot of times in the TAVR space. We're not looking at just replacing the valve, but really restoring the native valve. And so I'm Chris Meduri, and I'm going to really kick off this session today. But the goal today is to really give you a better understanding of DurAVR, which, again, is a new class of TAVR, a valve that's really designed to restore native flow. All right, let's get this moving here. Can we put the slides up, please? Yeah. Perfect. So I'm Chris Meduri. I'm at Karolinska University Hospital in Stockholm, Sweden, and I'm also the CMO at Anteris Technologies. So I think really to start the conversation, we have to go backwards because we have to ask ourselves, what have we been doing for the last 15 to 20 years? And to be honest, the goals, and when you look around the other TAVR devices that are being developed, the target has been, how do we make a better version of a bioprosthetic valve? And personally, as we started this quite a few years ago, we asked ourselves a different question. How do we actually design a valve that actually instead mimics the native valve instead of actually trying to mimic a bioprosthetic valve? And I think that's fundamentally the difference you're going to see here today as we look forward and we see all the initial results for this technology. So for some important background, this wasn't just kind of a convoluted idea by a bunch of friends. This was actually built off of a company, Anteris, that has a long history of development of bioprosthetic or tissue technology. So this cutting-edge tissue technology has actually been around since 2014, being FDA approved, and has been used in over 55,000 patients now globally in the cardiac space and as well as a vascular patch. And it's been clinically proven to be calcium-free up to 10 years. And there's a long source of literature that really supports this conversation. Now, I think it's important because if we're going to talk about building a backbone of trying to mimic a native valve, we want to make sure we have the right platform to be able to do that. And so first Anteris, who had been selling this tissue for a while, asked themselves, listen, what is another space we could be moving into? There seems to be a lot of opportunity in the TAVR space. But again, the question was not, how do we make another bioprosthetic valve? Is, well, what is the unmet need in the TAVR space? How do we ask ourselves different questions? And that question really was, well, if we're going to go after a new target, what does a healthy aortic valve perform like? And then after that, we asked ourselves, okay, if this is what it performs like, and we've now established those benchmarks, how do we actually try to mimic that valve? Then we have to put it on a stent. And lastly, we have to actually be able to deliver it pretty effectively. So that wasn't just done now. I think those are important questions, but they weren't done in a silo by a group of engineers and some people in industry. It was actually done by a company that said, you know what, these are important ideas, but we actually want to engage the key leaders globally and ask them how to actually find the unmet needs and how to actually build to them. So at that point, some of which are on the podium today, including myself, were initially engaged and asked that question, what are the unmet needs in the TAVR space? What are the compromises? What are younger patients in need? And to be honest, it took us a few years to get there. I mean, we had a lot of times we were looking at designs and trying to sort this out, and it was a struggle. But eventually, we think we landed on the sweet spot that you'll see today really is transformative. And what we identified was that if we wanted to mimic the native aortic valve, we couldn't do the same thing everybody else does. We couldn't take a piece of tissue and cut it into 3 pieces, sew it onto a stent, and try to mimic the bioprosthetic valves that exist today. We have to look at it differently. How do we mimic what a healthy valve looks like? The only way that's done is by taking that single piece of tissue, just like the body's valve itself is, and molding it to the shape of the native aortic valve. And that hence allows us to actually have native, healthy-like performance. Now, we said all that was important. Well, of course, we have already mentioned the backbone is having an incredibly durable tissue with these important anti-calcification and anti-fibrotic tissue properties. But to design a valve that also had long coaptation length to reduce stress, that was balloon expandable because it was felt to be important at the time that people wanted an easy-to-use valve. The struggle was we were trading off when we were using an easy-to-use valve because there was a compromise in hemodynamic performance. We also wanted to be able to have commissural alignment as well as coronary access. So building on that then, we took this adapt tissue and molded it. Now, I think it's important to understand, well, why haven't other people done this? Why is it not, people thought of it this way? Well, it's important to understand that this unique adapt tissue process allows this tissue to be molded. You cannot just take a normal bioprosthetic, bovine pericardial tissue and go mold it into this shape. You have to have the unique, securely IP-based properties of this tissue to actually provide this unique shape. And I think it's important to recognize what this tissue actually has in it. This tissue has undetectable levels of free aldehydes, which is a big driver in the calcification process. But additionally, you find no alpha-gal, no DNA or RNA remnants, and no phospholipids. And again, these are all part of that inflammatory response that contributes to degeneration. Now, that's great. You have a great tissue, you've molded it, but I think it's important to understand that by building this biomimetic design of it, again, it really does normalize flow and reduce leaflet stress. And what you can see here is that unlike a bioprosthetic valve that typically has a couple millimeter coaptation length at best, what you see is this incredibly long coaptation length. And what that allows this valve to do, and Mike will talk about it a little bit more, is it allows you to avoid any pinwheeling and additionally significantly reduces leaflet stress. I think these are all, again, key components to durability, and you can see this here. This valve, as it opens and closes, is really what you want a surgical aortic valve repair to look like when it opens and closes. This is what you want a healthy aortic valve to look like. As I already mentioned, and Susheel will get into more, it is an incredibly easy to use balloon expandable system. This valve is in and out of the body within a few minutes of putting it in through the sheath. It's that easy and intuitive to use. It's a very robust 14 French expandable sheath system. And again, Susheel will get to that a little bit more. But I think lastly, what I want to touch on before I pass this off to my friends and colleagues here is, we built a valve, and you'll see the hemodynamics are really unparalleled clinically as well. But what we think is also important is not just how wide it opens, but how it opens. And this is something that hasn't often been looked about in the field, but I think it's going to be a really important topic in the near future. And that's the word we use, kinematics of the leaflet. So how does it actually open? And if you actually watch here in slow motion, what you'll see is this. So in a traditional three-piece valve, as it opens, it really hinges like a door. So it is three different leaflets, and they essentially are swinging open and closed like this. Conversely, when you watch how this DurAVR is built, it allows you to build native-like flow, and because you end up puffing, as you can see in the DurAVR leaflets in the middle here, and then popping open. So there's not this turbulent flow that's coming out here and there. So as you watch this move slowly, you can see that this just goes from puffing to popping open versus this kind of door opening appearance in the other ones. So I'll let it play one more time, but I think you can appreciate here that there's distinct differences in the leaflet kinematics to allow you to have a more native-like valve function. So in summary, we can talk about a lot of things here, but I think what's important to understand is this valve, with an incredible history of tissue technology with the company, was built not to make another bioprosthetic valve, but it was built to mimic the native valve, which is what could be a better target when we're talking about best possible therapies for our patients. It is made not just by a group of engineers, but you'll see about the intuitiveness of it, and you'll hear in our conversation today, this was physicians who we talk weekly or every other week with engineers embedded to figure out what do users need to get the right results. And it has incredible coaptation length as well as the tissue technology we think will provide benefits from a durability perspective, acutely and long-term, and opens and closes differently than other valves. Thank you.
All right, shall we start with some of the discussion maybe? Basically, you introduced new terminology. You mentioned this biomimetic valve. Michael, is this truly a different class of valve technology, or is this more of the same? What is your opinion on that?
I think this is a different valve design. I mean, when we look at our valves and we wonder how they're going to work, how long they're going to work, we look at valve design and tissue science. And this has really incorporated both of those. One, in the valve design, using a single molded piece with fairly high commissures, which allows it to spread the stress across the leaflet. It's going to lead to not a better opening, but a better closing force, and it's also going to lead to better valve durability, I think. So I think this is something that's completely different. I mean, we know that at least in the world of surgery, there's only one operation for aortic stenosis that gets you back to a normal lifespan, and that's the Ross, because I give you a normal valve. And so the closer I can mimic an aortic valve, the more biomimetic you become, the longer the valve is going to last. And I think that this will translate into clinical outcomes, which we've seen, I think, in other trials based on hemodynamics and durability.
Yeah, great point. Goes.
Yeah, no, I wasn't really going to ask the question to Vinny because I always learn so much about surgical valves and so on from Vinny. So Vinny, up until maybe a year, 2 years ago when Chris approached me, I had not heard of Anteris. And then I suddenly find out they have this long history of actually making tissue and of having a special treatment for anti-calcification. Maybe you want to give us some comments because you've seen a whole array of different technologies for valve tissue.
So in surgery, we use pericardium patch or pericardium in many places. I think the commonest two places you can associate easily with is, one is RVOT patch or in pulmonic side. And many times it's not just the patch, you can make a unicuspid valve as well. And the second, which is now very common, is root enlargement. And in both these sides, one of the things we learn is when we reoperate is these can become calcified. And then they pose a big hazard in terms of managing it at that point. And that is the reason this particular tissue technology has been used on the pulmonic side in over 50,000 patients and has shown hardly any calcification. So although one may say that it's less dynamic at that point, but the duration it has been used is long. And that, I think, points us that this anti-calcification works.
Absolutely.
And I was going to toss it to Anita because, I think your comment, Mike, about the Ross procedure, and I know, Anita, you have experience with a lot with that from your center and the MRI perspective. And do you think that's, as we've talked about biomimetic and the benchmarks, what do you think when you've seen this valve, obviously in use in your own practice, and the importance of trying to, have a percutaneous Ross essentially procedure, right?
Yeah, I think the Ross is really the gold standard, and so we have quite a large population of those patients. We do a lot of adult congenitals, a lot of these young bicuspid patients that are getting Ross procedures. One of the things we've seen on CMR is how the dynamics or the hemodynamics of these valves are essentially like a native valve.
Yeah.
And I think that is the gold standard. That's what we're all looking for, to replace a valve with a valve that behaves like your own. And Joao's going to talk to us a lot about what he's seen in CMR, but I think it's really exciting times for patients who are going to need aortic valve replacement.
By the way, what is the importance of the coaptation length? Because it was clear from your slides that you see there's a longer coaptation length with this technology. Is this something relevant, or is this a trivial finding?
If you go back to aortic valve repair, valve sparing roots, one of the things that they teach early on is that your valve should look like a pair of praying hands with the heel of your palm at or above the annulus and with at least 8 millimeters of fingers touching. And the more coaptation, not only does it relieve the stress, but it gives you more leeway if it starts to expand in any way to prevent AI as time goes on. So if you look at this, that was over 8 millimeters, and if you looked at the heel of the praying hands, they're above the annulus. Those are exactly what we look for after aortic valve repair.
So what is a typical coaptation length?
Yeah, so 8.4 millimeters has been the mean.
8.4?
8.4, yeah, which a normal transcatheter or surgical valve is usually just a couple millimeters
Yeah,
in
it's
length.
3, yeah?
Yeah.
So, what struck me today as well is that our terminology when it comes to TAVR has changed. We never spoke about coaptation length for over 20 years, right? Yeah. So now we're talking about coaptation length. And the other topic, or the other new terminology that we're talking a lot more that you mentioned is pinwheeling. Susheel, how important is pinwheeling? Maybe you want to explain what pinwheeling is for the audience and how important it is.
Sure. So, I think when we talk about a lot of extra tissue, we're always worried that the valve won't expand. And so if you have an underexpanded valve, a tri-leaflet valve, and you're going to see pinwheeling where the leaflets are sort of rotated as they close. And whether that's going to lead to leaflet thrombosis or early degeneration has always been a concern. That's especially a lot of these terms came up when we're doing valve-in-valve with sapiens in prior surgical valves where you're not fully expanding the valve. And the engineers have always taught us that, to get a proper hemodynamics, and not only just opening but closing, you have to, fully expand the valve. And I think part of the challenge is that, in a lot of these, it's not, we have 3 sizes and the ranges are broad that you implant these sizes in. So you don't fully expand a valve because the anatomy is going to limit you or you're going to injure the root, whereas in surgery they're taking it out. We're sort of limited by the anatomy. And so when the first time I saw this, I actually was worried about it because my notion of redundant tissue and extra coaptation, I was worried that that's not the right approach. And I know what Mike is saying, and this is more like you see the closing, it's the coaptation, but it's not rotating or pinwheeling.
Yeah, and I think it's a great point because what we've seen is that on the bench studies that unlike most valves that you have like a 1 to 2 millimeter sweet spot from a size perspective, there's no pinwheeling around 6 to 7 millimeters in size because these praying hands stop the valve from rotating on each other because it's like a blanket holding it straight up. So one last question before we move to the next one. Azeem, I mean, you use all sorts of valves all the time. I mean, where is this need or where are the trade-offs today and what is the need still in the space?
Yeah, absolutely. Sometimes wonder why do we need so many valves, but I think we do, and I think that need is becoming more and more apparent as we start treating patients who are younger with longer life expectancies. Our standard of what we'll accept in a young patient is just has to be very high. It has to be as good as when Vinny and Mike put in a surgical valve. We have to be able to give patients, without exception, low pacemaker rates, no PVL. But more importantly, is we need to start, as we talk about this lifetime management, it shouldn't be only about, what TAVR valve we're going to put in when that fails. We need to start talking about, can we choose a valve and find a valve that's going to last the patient even longer, so maybe we don't have to worry about what's the second or third valve down the road. And to me, I think that's the part I'm most interested in, is can we find a valve for a younger patient that's going to last them as long as possible?
Yeah, no, absolutely. So, Susheel, you want to take it next? Sure.
So Susheel did a cool live case earlier today in a bicuspid valve, but he was still relying on TEE guidance. What's the story about that? I don't do any echo anymore.
Because we focus on excellent results.
Oh.
Ouch. Ouch.
Patient-centered care, not physician-centered. Sorry. All right, so moving on, thank you very much. So it's my pleasure to sort of present some of the initial experience with the DurAVR system. These are my disclosures, most relevant. As a consultant for Anteris and did some of the first cases with the device with Chris and the rest of the team. DurAVR has a reasonable experience. It's over 50 patients, 56 patients. The first in human experience outside the U.S. was 41 patients and a U.S. EFS study of 15 patients. These were single-arm studies, and just to get the initial experience, understand the sort of the system and get some safety and feasibility of and allow us to iterate the system during this process. And I think that's what EFS is for. And I think we've iterated this device from the first in human and the way the balloon works, the way the device tracks, all the different components, because we learned during the course of an EFS, which is what really was important. And I think that's sort of the feedback that I think was important for me, and that was sort of to be Chris's point that there was a team that was sort of giving feedback and the engineers were trying to make those changes is really quite relevant. And then there are core labs to look at sort of the obvious important endpoints with transthoracic echo, CT, CMR, and try to really understand, is there differences? How can we optimize this further? And obviously there will be ongoing follow-up. The outside the U.S. is just 1 year, but the EFS is out to 10 years. You see the sort of the baseline demographics is just a limited demographics. They were sort of intermediate to higher risk patients. The SDSs were 3 in the first in human and 5.8 in the EFS. Important to note, the area-derived annular diameter was under 23. It was roughly in the low 22s. That's because right now at this time there's only one valve size, and that sort of dictated obviously some of the sizing. So that's why you see most of the experience. And when you look at the gradients and you look at the hemodynamics, it's important to keep that in mind. And you see the typical sort of risk factors that we see in TAVR patients. I think Chris mentioned this a bit. It's a balloon expandable valve. It's sort of what we're familiar with. But the balloon is different. It has been iterated to provide stability. And part of it is, and we're going to talk here, is there's commissural alignment with this device. There's a knob in the back that allows you to rotate to get commissural alignment. But one of the challenges that we noticed in the initial EFS is when the first iteration of the device, when you rotated, you inflated, it was somewhat unpredictable. You lined it up, but as you inflated, the balloon characteristics or the valve would rotate, and so you didn't end up where you thought you were. And that's where there's been a lot of time spent on the balloon. That it's now that the valve is stable now in terms of its rotation as you inflate. It's a steerable catheter, single direction steering to help you navigate the arch. And then there's a 14 French expandable sheath now to help with the vascular access. This is typical what you see. It's a 14 French. But these are as a physician, these seem very simple, and it would be frustrating why things didn't work. And it seems like we've been used to the E-sheath for a long time. I know there's with the eye sleeve and things, and there are challenges with this, and it took some time. But the initial cases were done through much larger sheaths, either a 22 French Gore or other various commercial sheaths. So it had to iterate down, but now it's through a 14 French E-sheath. You see here there's flexion typical to what we see with the current balloon with the Edwards balloon expandable system, but the valve is crimped on the balloon. There's no withdrawing the balloon. The valve is crimped onto the balloon, and the balloon is different. It's got these, and I think that was a lot of the engineering. And I can't really explain it, but part of the characteristics was you needed to be able to be reliably crimp at the same spot, and you wanted the balloon to expand reliably. Because I think we learned from the early partner days that there was a lot of asymmetric expansion of the balloon. And when you get asymmetric expansion of the balloon, you see motion of the valve up or down and during deployment. And I think that's one of the concerns. So you wanted like a dog bone type expansion, which helps stabilize the valve during deployment, and that they were reliable for shortening. Because part of the simplicity of balloon expandable is you put it in the position you want, you inflate the balloon, and it sort of locks into where you want it to be. But if the balloon characteristics aren't optimized, that won't happen. I think there was a lot of learnings, and from early iterations of the balloon to where we are now is quite different. As I said, part of it is about the rotational characteristics as well. So then you use these tabs, these sort of figure. I don't know if I can point here. You can, when you rotate the back handle, you based on CT and by your initial angiogram, you know where the commissures are, where the coronaries are. And again, we can talk about commissural alignment or alignment to coronaries. Obviously, it's very different. When you're doing bicuspid valve, do you align to what commissure or do you align to a coronary? I think for a lot of us, what we're talking about with commissural alignment is coronary access, so we tend to more align to coronaries. But you can rotate and you align these in a manner that as the valve inflates, you'll get commissural or coronary alignment. And then again, I'll let this play a few times, and what you see, and we'll let it play the first time, and what you want is, and what you see sometimes is frustrating, is as you're starting to inflate, you see the balloon sort of slide on the valve. And what we wanted to do was avoid that. And there are these stoppers here that are nitinol that hold the valve in place. But the easiest way to look at it is look at this marker, and the valve stays very stable on the balloon during deployment. And obviously this is one case, but the experience more recently has been that with multiple cases, this is what happens, and I think that's an important feature. And I guess you're gonna have to learn that over hundreds of times in cases.
I think the other thing I'd add on that one, Susheel, is this is in the right left of you, and so you can the commissural posts are on the outer curve there, the two overlapping ones, and then you have one that you don't see on the inner curve, right? And so I think what's important to recognize is, like you said, it doesn't rotate, and that was a lot of work to do that. But you see this goes straight out, and also it's pretty nice is the commissural posts actually stay in place during inflation as well. So actually for valves, actually did a TAV recently, and you can use the commissural post to put it on node 5 pretty easily and identify your spot as well.
Yeah, and I think that's the feature that the first. I remember in the beginning the cases that we did, these would rotate and it wouldn't stay stable. And I think this took some time, and it's really about balloon characteristics, right? You can align, but if the balloon is going to rotate, the valve as it inflates, that's obviously a challenge. So real quick, these are the initial safety results. From a primary safety endpoint, there was one mortality in the EFS data. And then you look at the other events, one stroke, pacemaker rates in the initial first in human around 5%, typical what we see with balloon expandable, no pacers in the initial U.S. experience. There were some vascular complications early on, and again, as I said, early on we used the 22 French Gore sheath, and so it's obviously plays a role in some of it. And the rest of the events you see here are pretty low and pretty typical what you see with current commercial experience. And then there's been a lot of talk about hemodynamics, and obviously that's been the main focus. And so this is, again, a valve in a mean annular size of about 22 millimeters. You get EOAs of 2.2. Mean gradients of 8. And what's important is I've started to focus a lot more on DVI. And this DVI is a lot, 0.6 is a lot more than we typically see. We typically see DVIs 0.35, 0.4, 0.45, but this is quite remarkable. And again, it measured to the hemodynamics. You see here again, this core lab data, the DVIs as well as the valve areas. Consistent valve areas over 2 with this valve for this annular size, and the mean gradients less than 10, around 8 to 9. That stayed consistent. This is the initial first-in-human experience. This is the data for the US EFS experience. And again, you see in this data one pacemaker at 6.7. No other mortalities here that you saw. Then again, hemodynamics quite similar, reproducible 2.2, mean gradients around 7.5, and again, DVI is above 0.6. No significant PVL. In the previous experience, again, no significant moderate PVL as well. And again, you see the hemodynamics. Again, this is only 30-day data, but you see the results here. So, this is initial data. It's 50 patients. There's been iteration of the valve over the course of these first 50 cases. In terms of not only not the valve as much, but the delivery system to get these consistent results. The hemodynamics has been excellent with a single valve size. It's a predictable balloon expandable delivery system, and the global pivotal trial is going to be starting next year, and so we'll get some data in comparison to existing valves and see how it performs. So I'll stop there. Thank you very much.
Great. Anita, you want to comment? You've used it now quite a few times in valve, and just talk about the ease of use, because I think it's we're all busy operators, and maybe a lot of people who come to these meetings are very experienced in TAVR, but I think it's important to make sure the technologies as they translate are pretty intuitive. What was your experience?
Yeah, so we've done 5 cases. We're going to be presenting our data tomorrow in a session, so I encourage you to come see that. Essentially, we decided to do these cases under special access for particular reasons for these patients. So they were patients who didn't have bypass grafts, even though they had an AVR, and we had concerns about leaving them with high gradients, and so we chose DurAVR. And so, we had never done a case when we did our first valve in July of last year. It's very intuitive. It's like the technology that we already know how to use. The commissural alignment was easy, and that was sort of the earlier generation that we did on our first case. And so I think it really does utilize the skills that you already have and the knowledge that you already have to be able to deploy a valve. I think crossing the valve was hard in a couple of our cases, more than actually putting the valve in place because the gradients were so high. But it's easy to use. There's nothing very foreign about this at all.
And Vinny, you've been in a ton of the cases now. I think as many as me almost. The last time we did 13 just last month, and we were flying through. What was your experience?
I think Susheel highlighted the changes, which is important. Any new device you start, device delivery system, both have to be, married together well as well. And the last trip was phenomenal in terms of seeing the changes, not just on the second generation valve, but the delivery system and the sheath. Yeah. And hence the procedure has become very streamlined now. And again, the duration of the procedure, despite multiple checklists, is really short. So as Anita said here, it's something which we already do, a balloon expandable. It's no different anymore.
Is pre-dil mandatory?
No.
Not
you don't need a pre-dil.
And I think I would congratulate the engineers on that. I would say that the features of the nose cone and the delivery, the catheter and the balloon is such that the pre-dilatation in a very horizontal bicuspid-like anatomy calcified, it's still easy to cross. Yeah.
So I think it's interesting. So a few of us have spent years on calls talking through this, and a lot of times we do a lot of things in practice and we think we understand how things work and why they work, but then when you dig deeper on the engineering side, you realize maybe you didn't really understand it the way you thought. So one thing that we spent a lot of time was on the nose cone, actually in distal stop, and actually interestingly, the first time they mentioned to me, can we have a tightly woven nitinol distal stop? I was like, why would we use nitinol to hold something in place? And it's actually quite fascinating because the way it works is unbelievable. I mean, it lets you smooth out your frame as you're crossing the arch. It lets you have just enough give as you actually are crossing the valve. And as you're actually pushing through the expandable sheath, it really allows you to track those contours a bit easier as well. So I think credit to them that they've done a great job really getting a creative solution to some of the things we see clinically.
Well, and the other important feature, and that seems simple, but it isn't, is the short stent frame.
Yeah.
So I am very much in favor of avoiding stent frames in front of the coronaries. And Susheel already mentioned commissural alignment or coronary alignment. But basically, if you have a short stent frame, you don't need to bother about a coronary alignment. You just want to focus on commissural alignment because that might affect your hemodynamic valve performance. Mm-hmm. So then you don't need to make any concessions in terms of your commissural alignment. If you have a stent frame in front of the coronaries, that's where you may want to opt for coronary alignment to make sure that you will be able to re-access the coronaries if needed. So I think that is also an important, very simple but very important feature of the valve.
I do think. Sorry. Yeah. I was just going to say that when you're doing this size valve in these annuli, even balloon expandable is going to be to the sinus in many, and that's where I think the coronary alignment in a large open cell I think is valuable. So I think that the top cells are open because it's a short frame, but when you're doing 26 and 29 valves, you often are below the coronaries. But I would say a lot of these, especially in women, a lot of these 23 valves, you end up above the coronary. So getting the alignment and having a large open cell for coronary access, I think, is important. And the next generation is going to be this. Right now, it's a little bit taller than a 23 Sapien, and the next generation is going to be, I think, 3 or 4 millimeters shorter. So it's going to be comparable to the current.
Now it is. The new generation is actually now. Yeah.
But when you talk about commissure and coronary alignment, you got to remember that even if you have a bicuspid with 180 coronaries are never behind the commissure. They can't be. Mm-hmm. They can be above it. Yeah. They can be to the side of it. And so unless your post goes above your normal commissure, no matter how your coronaries are, if you line up post to post, your coronaries are going to be okay.
Yeah, and I think it's a great point. I know I think I saw Roxanne in here earlier, and I know Mike's here from the SMART trial data and looking at, I think we talked about annulus size and looking at some of the hemodynamic results. Azeem, I mean, I've seen you talk on this before, but I mean, this really, I think, goes back to a different class because we've just talked about the short frame, right? And we've consistently seen your short frames or balloon expandables that we are compromising hemodynamics. Maybe there's some mild improvement now, but still not normalization of hemos. And it seems like now, at least with this design, that we're able to really get to evolute, if not better, hemodynamic performance. But what is kind of your thoughts looking at that compared to maybe some of the SMART data?
I guess what I take away when I look at all this data is that we all have to accept that not all valves are created equally, that not all TAVR valves are the same, not all self-expandable valves give you the same hemodynamics or can be put in the same class. And similarly with balloon expandable valves, we're now coming into a world where I think in the next few years, we'll see here in the United States multiple balloon expandable valves. And because we deploy it on a balloon doesn't mean they're all the same. And I think that's going to be really the important discussion, right? Is what are the differences between different technologies? And it's going to come to, because I think when you talk about balloon expandable, ease of use and reproducibility are really the gold standard and why many people like the valve. Then it's going to come down to frame height. Do you have commissural alignment? How reliable the commissural alignment is? What is your tissue made of? And how long that's going to last? And because, not all of us are going to be here 20 years from now still doing valves, you also want to look at, are there any early changes as regards to hemodynamics, gradients, valve areas, and maybe some unique features that João will tell us about later that will be able to say maybe one valve has some advantages over another valve. So I think, this area is still a very important and wide open area. And I'm glad SMART came out because it's forcing us to address the fact and talk about the fact that we can't use one valve in every patient, every anatomy, that certain valves do better and that there are other factors that are important to our patients in making a choice. And so we're going to have to get better at choosing the right valve for the right patient.
Yeah, no, absolutely. Mike?
Ready?
I think it's up to you now.
Well, I know a lot of the people in this room, but for those of you that don't know me, I'm Michael Reardon. I'm a cardiac surgeon from Houston, and I've been doing cardiac surgery for a little over 40 years now. And my clinical and research interest has been cardiac valve disease, particularly aortic valve disease. And so I've been very interested in hemodynamics and why hemodynamics matter. We already mentioned earlier that the Ross procedure is the only thing that gets you back to a normal lifespan because it mimics your real aortic valve. And the closer you get, the longer you're going to live. We have lots of growing data that any level of aortic stenosis, even mild, shortens your life. The ECHO database from Australia shows us that. So we really want to get back to as close to normal as we can. And you've already seen this slide. Susheel showed you this. So if you look at the first in man and the EFS, so EOAs, 2.20, 2.18, both very good. The problem with EOA is it's fraught with errors because of measurement. In fact, when we started core valve, my echo lab would not even give you an EOA for a surgical valve because measuring the LVOT was so hard. They only give you a DVI because that's the only thing they thought was accurate. In fact, if you look at the literature and you read two different studies with the same valves, one have an EOA of 1.8 and one have an EOA of 2 because they were read by different core labs. In fact, we've looked at echo core lab versus sites for the Paragon trial, and one of the things that doesn't correlate is EOA. EOA is fraught with error. Mean gradient. Mean gradients do correlate between echo core labs and sites. The problem is they're flow dependent. And so if you don't know the flow, you don't know. One thing that's independent of both of those is Doppler velocity index, DVI. So why is DVI important? Well, DVI is important because it just comes from the continuity equation that flow below the valve equals flow at the tip of the opening of the valve, the EOA. And the flow below the valve is the LVOT area times the LVOT velocity times index, that envelope you see on echo that summarizes all the instantaneous velocities across systole. And that equals the EOA, the aortic valve opening, times the aortic velocity times index. You don't have to measure any links for your LVOT. You're not going to lose by the square there because you don't measure. You're just measuring VTIs, and VTIs are pretty easy to measure. So if you divide the LVOT VTI by the aortic VTI, what that equals, that Doppler velocity index, is the ratio of that individual patient's effective orifice area to that individual patient's left LVOT area at that individual patient's flow. So it's normalized to flow, and it's normalized to size. Why? Because little people have little LVOTs and big people have big LVOTs. So if you go back and you look at like Becky Hahn's work, you'll see that no matter what valve size, the DVI is the same because it's not an actual number for the OA, it's a percentage of the OA to the LVOT. And of course, you'd like to be as close to 1 as you possibly can get. So if you look at DVIs here, DurAVR 0.64, Evolut 0.61, that comes from Becky Hahn's work when Becky went back and looked at the core lab echoes in the Evolut trials and the partner trials, and SAPIEN 3 was 0.42. So that's 64% of that patient's LVOT, 61% of that patient's LVOT, or 42% of that patient's LVOT. In the Evolut trials, when we did this, I went back and looked at the mean surgical was 0.5. And that's why I think when you looked at the Evolut trial, the durability turned out to be better and the survival turned out to be better because it's clearly better hemodynamics. Now, we've talked about this coaptation length. If you look at this, again, I tell you, when you look at this, we know from aortic valve repair, because we do a lot of those now, that you want to see your praying hands, the heel of your hands, at or above the annulus, and you'd like to see at least 8 millimeters of coaptation. That coaptation allows you to even overexpand the valve without developing AI. It spreads the stress out across that, and it does not cause you to pinwheel. Pinwheel is the length of the leaflet, not the amount of coaptation you have. What this does is reduce stress, and it should make it last longer. And because of the way it's folded, Chris has already shown you that it opens up better. It opens up in a better fashion, and it opens up more fully. And that's why you're seeing the DVIs that we're seeing. Now, there's really no pinwheeling. I'm not going to go over this again. You've already seen this once. But pinwheeling, so I'm grateful for pinwheeling because when I was a young surgeon, there was a valve called the Inescu-Shiley. Everybody but maybe Eberhard is too young to know this. But it was one of the first tissue valves ever, and I remember because we're getting up there. It was a tissue valve, and it failed. Why? Because they put in these very long leaflets to try to prevent leakage, and they pinwheeled, and they all failed. And so I spent a lot of my early surgical career taking out Inescu-Shiley valves. And people learn from that pinwheeling is a bad thing because the leaflets lengthwise fold on themselves and they twist, and they fail because that creates stress points. Now, we also see with this valve, and I'm not going to say much about this because this is really going to be for Giles to talk about, is more laminar flow. Laminar flow is crucial. Anytime you get turbulent flow, you lose energy. And what the heart cares about is how much work it has to do to get the blood out of the heart and around the body. And work is force times distance, and force is mass times acceleration. And if you get laminar flow, there's less energy expended getting that blood forward than if you have chaotic flow. Now, you can measure this with echo, because in laminar flow, the velocity changes from the wall to the midstream, whereas in turbulent flow, the mean's the same across there. But you're losing energy. You can do this with echo, but it's much better done with CMR, and I'll let João comment on that. But I do think that when you look at this, and one of the things that we're starting to look at as a field is not just how big the valve opens, but how does the blood flow across the valve? And laminar flow is one of the key things, and that's one reason why tissue valves, in some ways, are a little bit better than some of the older mechanical valves we had that had single disc, because those single discs cause very turbulent flow, where central openings start to lend themselves to laminar flow, but not all of them end up laminar. And again, this is just an echo to show. I'm going to skip over this. You can do this with echo. It's not really the way to do it. The real way to do it is do it with 4D CMR, and it shows it very nicely. So hemodynamic performance matters. Hemodynamics affect your survival. Hemodynamics affect your ability to recover and do what you want to do. We know that severe patient-prosthetic mismatch impedes your ability to exercise. And the smaller your valve, the smaller your EOA, the harder you're going to have doing the things you want to do, particularly as you move to younger, more active patients. And DVI really is the metric I think we ought to all be looking at. I mean, it's much more important than EOA, which is fraught with errors. It's much more important than mean gradients, which are important, but they're all flow dependent, whereas this is independent of flow and independent of patient size, and it gives you a good valve-to-valve, patient-to-patient metric to look at. Pinwheel and coaptation link can also be seen in echo. These are really early signs of what I think are going to be increased durability, things that we know of from aortic valve repair. And laminar flow can be seen on echo through all levels of the valve, and it may explain some of the hemodynamic performance. When you look at the CMRs, you'll really see this. You look at a normal valve, and you look at a DurAVR, and what you see is you get the same type of laminar flow. And again, the closer you can get to the valve God gave you when it was working, the better off you are. Mm-hmm. So I'm going to stop there, and we'll move on to either questions or the next one.
Well said, Mike. I think for the sake of wanting to have more conversation, thank you. Let's jump to João, because he's going to build on that in the flow perspective, and then we can really kind of settle in on some of these other clinically relevant differences.
Well, thank you so much, Chris and Anteris, for this opportunity. Presenting here work that is being done by a colleague as well, Pankaj Garg, from Norwich in UK as well, that helps us tremendously in the development of this. Some disclosures that get consulting from Anteris. So set the stage that aortic valve, we're talking about aortic stenosis, but this is not just a disease of obviously the valve, it's the disease of the valve of the ventricle and of the arteries. We're talking about arteries too, yes. So in a patient with severe aortic stenosis, obviously there has to be some compensatory increase in the wall thickness to accommodate the increased wall stress. And by doing that, it comes at the expense of obviously having fibrosis scar that you see here by late GET. After you do AVR, provided that there is no prosthesis-patient mismatch and there is good control of hypertension, and you have a healthy arteries, you're going to regress this hypertrophy. You're going to regress even some of the interstitial expansion, which is by the collagen that we can measure by MRI. So a good artery should be pulsatile. They should be able to accommodate the blood flow. And in diastole, they should continue to propagate that flow. So that perfusion continues in diastole as well. So what happens with aortic stenosis? Normal aortic flow should be laminar. So the Vmax, the peak, the highest velocity should be at the very center of the vessel, not touching the walls. And obviously with aortic stenosis, we're going to distort the blood flow. And so the flow gets erratic. It gets distorted. There's turbulence. And there's going to be more wall shear stress because it's going to hit the wall of the arteries. Well, these arteries are not going to like, and eventually they're going to become stiff. And that stiffness is going to create, obviously, some reflection of these waves. And even in systole, it bounces in the wall and it travels back again. So you're wasting energy. And this ventricle is wasting even more work. So it doesn't like that. So this is a non-laminar, this is a laminar flow, and this is a non-laminar turbulent flow. Is that true? Well, this has been done with the 4D flow MRI. As you can see from healthy here, the bullseye, it starts to move into the periphery as we get more stenotic, different groups of patients. And some other concepts that are going to be important. How far are you from the center? That's called the displacement ratio, the distance from the centroid of the vessel. And this systolic flow reversal ratio, that is that reflection that comes back even in systole. So it's that turnaround because of the reflection of the waves. Well, there's an easy solution. Let's fix the valve. We tried that. We drew that with surgery. And this is some work that we had done together with the group at Penn, pre and post cardiac MRI. And it turns out that actually after you fix the aortic valve with surgery, you increase your aortic stiffness. Maybe you are unmasking because now the ventricle is talking directly with the arteries. There's no more impeding force like the aortic valve. So the compliance goes down, the stiffness goes up, and this reflection, which is that countertalk between the ventricle and the arteries, that pushback, is called the reflection magnitude, was inversely correlated with KCCQ. That is, the patients that had the highest reflection of the magnitude had the worst KCCQ improvement, and that was seen. Well, surgery did not work. How about TAVR? Let's go to TAVR. All right. So we do this looking at 4D flow, severe aortic stenosis. With 4D flow MRI, you can see that the flow is quite not laminar. It's eccentric. It's turbulent. It hits the outer curvature. You put a sapien here, but you could say it could be other valve. It could be a surgical valve as well. And you still have not restored laminar flow. That is a cross-section of the aorta, looking at exactly that flow displacement at 10 o'clock. Ideally, you like to have the flow down the center, right? Well, we have learned through this publication from Philippe Généraux, looking at the changes of aortic staging. Now we're fixing this either with surgery or with TAVR. There's not a significant improvement. You improve, obviously, some of the symptoms, but the changes of the heart that should occur within a 1-year time span did not happen. Only 15% had improvement. It's pretty much a lateral move for most patients, and some of them worsening. Is that because, are we too simplistic to think that one valve would fix everything? Are we doing a small benefit to these patients? Is that because there could be some other culprits? And one of them here that unfortunately is covered is hypertension as well, that it was one of the causes of lack of cardiac stage improvement. And that is that, again, importance of flow that might be related to that. When we look into both surgical and TAVR valves, again, for 4D flow, central flow is normal with mild eccentricity, severe eccentricity. This is in balloon expandable valves. We could see that whether we look at surgery or TAVR, we could see that eccentricity seems to be even greater with TAVR devices and greater flow displacement. And that might have also some implications into increase in wall shear stress, as we talked about, continuation of hypertension, amplification of that, and increase wall shear stress. So is there a way that we could do this without causing a compromise to the arteries? So we took this work at the Republic of Georgia, and I want to, again, give kudos to Pankaj Garg, good friend and colleague, who, working together with the group there, has been able to apply not only 2D phase contrast, as you see here, but even 4D flow, as we have now. Looking at the post-CMR flow pattern of DurAVR. So this is a normal healthy valve. There's no AS. As you can see, in systole comes, it fills out nicely here, the cross-section of the aorta. Flow displacement is minimal, and the flow reversal ratio is pretty much minimal. Here, 5 patients with DurAVR. You can see, again, same laminar flow. Contrast now, obviously, with severe AS. That's how they would start with before they got into the DurAVR. You see this very displaced flow. With sapien, you can see the same magnitude, not too different from actually severe AS. That's from the flow perspective. Evolute, we can see also some flow displacement and even surgical valves here with Edwards-Magna ease. So there was no significant difference between what you see post-TAVR with this device versus even a normal healthy aortic valve. So restoration of potentially normal flow, which might have downstream implications to the valve, to the ventricle, and to the arteries. Now, looking at this biomimetic design, again, just put into bar graphs this flow displacement, comparing healthy aortic valves with DurAVR and other competitors. You can see that there's greater displacement and greater reversal ratio with other devices versus what was seen with this biomimetic. But so we are talking about different languages and concepts and really lexicon here. We're talking about coaptation length. We're talking about how we can optimize the delivery of this balloon expandable valve. And now introducing the flow. I think it's quite a lot. So let's actually dial back down and understand maybe that's great. You can show colors, but so what? Right? So, I mean, show me that there is actually some benefit beyond what these colors would show. So what is the impact of actually doing something after restoring flow to the ventricle? So we need to look at the left ventricle. And again, this is a construct that cardiac MRI is considered the gold standard for precise quantification. Here we have 12 paired patients, pre and 6 months post. There is also some echo data obviously done by TAVR valves, and Brian Linden, who is here in the audience as well, looking at echo. But the precision of measurement of the echo is difficult because it relies on assumptions on the formulas, and a lot of that has to do with also the dimensions of the ventricle. But nonetheless, with MRI with 12 patients, we could see here that there is an important LV mass regression, which ultimately speaks for how did you unload that ventricle. And also improvement on left mass index as well by 29%. And if you can do this delta here, you can see that it's almost 20 points. Whereas, in this recent meta-analysis that was published, 9 publications, 246 patients, the average left mass regression was about 15. Of course, we're talking about one valve size versus across the spectrum. But needless to say that that benefit that was seen with also the gradients and the echo DVI that was presented by Dr. Reardon and others, might have also some implications into the ventricle. And we are very excited to see also the continuation of this data now here in US. This is the data from the EFS. There was 15 patients, and we have cardiac MRI in a handful of them. This is to be expanded now. We can see this pre and post cardiac MRI. There is improvement of the global longitudinal strain. The ejection fraction is already super good, so you cannot make it better. You could make it worse, but did not get worse. But you can make strain better. You can make the RV strain better. You can make also left ventricular mass substantially reduced, and more importantly, again, the restoration of the flow. As you can see, the red column of blood is the red down center, which was, again, something that we have restored from this obviously severe aortic stenotic turbulent flow. So my final thoughts is that, in the post-TAVR imaging analysis that we have seen so far demonstrates that this long coaptation length, similar to a native aortic valve, might have some very favorable benefits, not only from echo gradients, but also high OA and DVI. There is some very favorable early reverse remodeling that now has been seen by cardiac MRI, and obviously importantly, the restoration of this normal laminar flow. And obviously, the jury is still out whether these findings would have, obviously, some downstream impact into LV remodeling arterial stiffness that will be prospectively evaluated now with ongoing future studies and also the pivotal sub-study. Thank you.
Provocative stuff, João. Thank you. Thoughts from anybody? Immediate comments?
Well, I just want to say one thing. But I mean, I've been doing this a long time. We've always relied on echo, and I have nothing against echo. But the mass regression on echo is fraught with errors because of the formula. MRI is to me the gold standard, and the use of MRI for laminar flow, for extracellular expansion early on, for mid-wall fibrosis. We're learning so much about this that really affects, I think, the early signs of what's going to happen long-term to these patients clinically, which we never really thought about before. And I think imaging is really helping to drive this forward. And I think the things that João just showed you are all markers for something that you're getting more heart recovery. You're going to end up with less fibrosis as long as you do it early enough. And the heart's going to be having to deal with less work. Now, one comment about why after aortic valve replacement your aortic wall's stiffer, I put a big cut on it and I sew it up. Yeah. That makes it very stiff.
Yep. So obviously I haven't done it for such a long time, but I'm also very impressed with the MRI data. Is this going to be incorporated in the next trial?
Yeah, great question. Yeah, João.
Yeah, so we are very fortunate. I mean, talking about differentiating also in the way that we take science and take that seriously from the very beginnings, bringing everybody together. There was this impetus, and thanks for listening, because it's through these observations. If it was known, that's why we do research. We don't know the answers, right? So let's explore by cardiac MRI. We were looking at, how could we be much more precise in this reverse remodeling early on. But then let's add flow, because that might be quite unique as we start to see some of the preliminary echo data showing very high DVIs and very, increased valve areas. It's like there has to be some crosstalk between the ventricle and the arteries that we need to explore.
Yeah, but there are quite some logistic challenges with
course.
implementing an MRI study. So is it the ambition to incorporate that in
a
next
sub-study,
trial?
yeah.
In a
So in a
sub-study.
sub-study
Okay, yeah,
from the
sub-study.
pivotal trial, there will be obviously selected sites that will be trained, that will be able to do 4D flow MRI. But that's the beauty of a method like that is precise. You don't need a huge number of patients to show a difference because of the precision.
I'm building up my fourth hybrid room that's going to have a 1.5 Tesla magnet attached to the room. I can literally take your lab bed, roll it in, because we'll have a non-magnetic bed.
A 1.5 Tesla is outdated. It's 3 Tesla these days.
But actually,
Well, I have a
You don't
7
want it to
Tesla
go
that'll suck you right in there.
yeah, no, you don't want it to go high Tesla, a high magnetic field, because that comes with more problems with artifacts.
Yeah.
So 1.5 is what we saw here. That's beautiful. That delivers.
And I think,
can
what's important is now TAVR is established for 22 years. Every trial has taken us to the next level in terms of indication, in terms of flow. So I think this is probably the next level, right? Is stop worrying just at fixation and function, but is it adequate function?
Yeah.
And I think that's going to help us a lot.
If those of us that remember old campaigns in the U.S., it's the economy stupid, it's the flow stupid. Everything is flow, and it's how you measure flow. And when you look at how we treat these patients, the mantra should be, it's the flow stupid.
So, João, is there any long-term data correlating with this flow? I mean, I see the LV mass regression. Is there anything else out there, or are we rewriting now how this is going to be done in the future?
Yeah, there is some preliminary actually work on ROS procedure. And 4D flow and ROS, that is the one that restores the laminar flow.
And showing
And
that
for- and
it's
showing
associated
that-
with better outcomes?
Yes. It actually, when you do a ROS procedure, you are able to restore complete laminar flow from a severely stenotic bicuspid.
And you can show that on CMR.
Yes.
That's amazing.
So, whether this would have bad implications to unloading the ventricle, making some benefit to the arteries, and eventually durability, that's why we're excited about what the future will show. We don't know yet.
So maybe one more question to you and Chris, because when you show the different valves, and you guys at Minneapolis have also shown that with balloon expandable valves, valve expansion is important, right? For flow, for outcomes, for preventing heart. So that kind of flow we see, is it dependent on getting maximal expansion of the valve? And what impact is valve expansion going to have on flow?
Yeah. I mean, I think it's a great question. That I will say from some of the things we've seen from our earlier learnings and now, I think there's probably some role of both, but I think the design of the leaflets themselves play a much bigger role than the frame expansion itself.
Yeah, there's learning from the history of surgery. So we had a valve that we don't have anymore. It's called the Toronto stentless valve, and it was a subcoronary valve, and it was pliable. So you could basically put any size valve in any size hole. And some of these valves came out and had higher gradients much higher than you'd expected, and you went back and looked, and the surgeon put in a valve that was matched to a larger LVOT than the annulus, and so what happened is they had this extra tissue in there, and that leads to increased gradients, and it'll lead to pinwheeling. Again, pinwheeling is the length of the leaflets. I mean, underexpanded valves of any type are bad.
Yeah.
Yeah, with under expansion, obviously, comes more pinwheeling. Even the suturing of the leaflets, you show on those very nice kinematic renderings that you could see that there is some real estate that is lost by just the virtue of the commissural posts. These leaflets, they open completely, and they open very freely. So that might have an implication of what we are seeing as the flow measured by cardiac MRI. Is that a question?
Is there, yes, go ahead.
Hello?
Yes. Hello.
Okay. Good morning. I wanted to ask about if DurAVR has good potential for like aortic valve disease and rheumatic heart disease patients, especially young population, because we were like designing a trial for people who, like patients who have rheumatic heart disease and they have their mitral aortic valve affected, and most of them are women, and they seek for pregnancy, and sadly, if they made open heart surgery, warfarin is teratogenic. So we were like seeking for giving them an alternative option. So we had the choice on Evolut, yeah. And so I'm just asking you, do you think DurAVR has a good potential for this?
Are we talking about young women that want to have children and
Yes.
because these don't no matter
Exactly.
because no matter what kind of valve we put in this tissue, it's going to fail, and it's nothing but a bridge to either a mechanical or a Ross. So the only thing you can put in that's not going to fail is a Ross. I don't care what tissue valve. A young woman, particularly in the mitral position, is worse. But when we look at these are all bridges to allow you to have children to some eventual other procedure.
Which is not such a bad idea in
Yeah.
these countries, right? Because then maybe you take the 24-year-old to 34, and she's had her 2 kids, and then she gets some mechanical valve.
So some of the polymerase valves are now being tested over in India in young women who have mitral valve disease who need to have children, and if those valves last even 5 years, that's going to be a real plus because a mitral in a young woman wears out in no time at all.
But having said that, this is very important, and this has been already done with other devices. So I think in childbearing age group, means I've operated in Philippines, Indonesia, Malaysia, they still opt for surgical valves which are bioprosthetic. So why not replace it with something which will give you equivalent or maybe even more durability? Maybe it is 5, becomes 8. Or maybe 8 becomes 10. And I think this is going to be an important conversation going ahead. And all these patients are small annuli. So let's not forget that either. So as a surgeon, I don't want to do root enlargement in a 20-year-old. I would rather, reoperate at that time, do a mechanical. So very, very good question.
Yeah.
And yeah, congratulations on your study. That's very important
Yeah, yeah.
for,
Yeah, I
for
want to
women's
ask
health.
another question, sorry.
Yeah.
Do you think that, apart from women, like men, for example, do you think that DurAVR would be like stable in young population? Because we know that in like young population, there's no enough time for calcification. So like, there is no like, I was amazed that it has secure deployment over the balloon. So I believe maybe it has a good potential. It would be life-changing in third world heart countries.
Time will tell.
Yeah,
I think we need to do the clinical studies and prove to the rest of you
Yeah.
that the
Yeah.
durability is good.
Thank you so
Yeah,
much.
great
Thank
questions.
you for the questions.
So one last question as we're racking up, just back to João, and I think, just summarizing things today, or maybe I'll just summarize instead of tossing you a question. But I think, first of all, thank you to everybody in the audience, and really appreciate it, and thank you to the panel. I think the takeaway is that, this valve, with the credit to the people in the company, really decided to build something different, right? It wasn't just to make another bioprosthetic valve, but to mimic the native aortic valve. I think we've seen that was able to be done, not only do it, but do it with a really easy-to-use delivery system, and which is important. The clinical results are as good, if not better, than anything from a hemodynamic perspective. And further, I think there's really exciting evidence on the restoration of flow, be it laminar flow. And João, congratulations, that LV mass regression is remarkable on MRI, and I think it's going to be really exciting to see where those things go. A lot of us will be helping, or everybody here is heavily involved in the global pivotal trial. There are a few spots left actually for that, so if you're extremely eager and think you can crush it, come find a few of us, but it's almost tapped out. So otherwise, thank you for coming today, and we look forward to showing you more.